Hey guys, welcome back to the FOAMfrat Vodcast. I guess we're going to start trying to add some more video in. I was not part of this interview, but Sam, Ireland, and Jake Good talked about prolonged QT syndrome, which is something that I am definitely not in the know with. And honestly, Sam, when I think about it, like I was always taught, you got a patient who is in some sort of polymorphic VTAC. It looks like torsades, and they come out of that rhythm, and then you look at the QT interval, and if it's long, then you just give that patient magnesium. And then I watched your talk, and it just was like I realized there's so much I don't know about this syndrome, and the treatment pathway you go down could be completely different depending on if it's acquired or congenital. Is that correct?
Yeah, unfortunately, it's like it's such
So I'm screwed.
yeah, it's a rabbit hole of a topic, and it's not something common, And if you do have somebody that Jake did that recent little the video, the explainer video with the quiz and stuff, and he was talking about like the difference, like if they convert out, they don't have a long QT, then it was polymorphic VTAC, like generic. If they convert out of a polymorphic VTAC and they do have a long QT, well, then it was actually torsades. And those patients specifically were the ones that we talked about, the ones where it is specifically torsades. And so now they've converted out and you have this long QT syndrome. And yeah, there unfortunately is a big difference between patients who acquire it essentially through electrolyte abnormalities or medications or a toxidrome or really bad diarrhea or something like that. Like there is a difference between them and somebody who is now having an exacerbation of a genetic issue, which are those congenital patients. So it's really complicated, but we tried to narrow it down to like just the stuff that you would want to know, like what medications piss either one off. What would you do if, what is the standard treatment for if they're pulseless and stuff like that. So we try to keep it like what applies to both. And then at the very end, like a little bit of differentiation. And if people are interested in the differentiation aspect of it, that's mostly what the blog is, and going in kind of like the nitty gritty on like the channelopathies and stuff like that. But it's a horrible topic to research because anything you look up, like anybody who's ever taken a genetics class knows, like any genetic stuff that you ever look up, the literature is freaking dense. It's so
Yeah, I can imagine.
And there's so many different mutations that can occur that cause these various types. And so it really comes down to like, what is the treatment that can apply to like that? Cause that's the high yield stuff. Like what can you do that is going to help both of these patients, whether they acquired it or they're born with it? And then if you really are sure, like, through a few different methods of differentiation, that's one or the other, that's when you'd probably get on like in contact with some online medical control and be like, hey, I think this is what we have. Or even a transfer. If you're taking somebody who is like a postcode or something like that, and you're thinking like, how do we keep this patient from rearresting during transfer? Because the two patients, they actually are very different, but they can look very similar, which is unfortunate. So yeah, but
no
it was
kidding.
a really good discussion.
Well, I haven't heard the podcast yet, but I am going to I'm going to watch it later on today. Don't quiz me on anything right now, because like I said, this is not an area of expertise for me. And I'm curious why you even went down this rabbit hole of prolonged QT.
It was from a class that I teach in the refresher. So I do a class on pediatric ECGs, and there's a congenital long QT case in there. You guys are probably thinking like, feel bad for the students, but it was a case. I mean, one of them is like BER and it's just like benign and you can sign the patient off. One's like WPW, another one's an Adderall overdose. And then one of them is a coded patient who you bring them back and they have this really huge T wave that's like just dominating the TP segment, or where the TP segment should be. And we got to figure out kind of what to do with that patient. And a lot of people, when I teach that class, have a bunch of questions about long QT syndrome. And I found out through teaching that class that like I've never had anybody come back and be like, oh yeah, we covered this extensively in school. Like I know exactly what to do. Never once, because this is not covered like ever. So I figured it would be a good kind of like a fill in the gap, like knowledge type topic to cover, but it wasn't easy.
Yeah, no, it's super zoomed in, and I would have to imagine that like even your community ER doc is going to have to consult on this. Like this is not something that is just routine knowledge. So we were hoping, you know, with our outlet and our platform at FOAMfrat to do a blog on it, which you already released, put out some podcasts on it, some videos, and try to like normalize this knowledge a little bit. So should we get right to the video?
Let's go check in with Jake and see what he's got to say.
Sounds good.
So you just did a quiz online. We've been posting these ECG quizzes, and you had one that was about the torsades versus the polymorphic VTAC, and you differentiated those. So you have to figure out what the ECG is, or how do you differentiate between the polymorphic and like if it's actual, like call it torsades?
Yeah, so it's pretty much just like a definition difference. That's all it is. And so there's two different kinds of polymorphic VTAC, and there's generic polymorphic VTAC, and then there's the true torsades that we're familiar with. The difference between the two of those is, unfortunately for us, like you have to see what the underlying QT interval is to make the differentiation. So generic polymorphic VTAC, that has actually a normal QT interval. There's no prolongation, and that's usually the result of, you know, cardiac ischemia or something like that. And then on the other side with torsades, would have the QT interval or the prolonged QT interval, and that would be the definition of torsades. But unfortunately for EMS, like, you know, how often do we get there and they're just like, oh, that's polymorphic VTAC. And we have a tendency to call it torsades, but, you know, to be the definition stickler, there is a differentiation between the two.
Gotcha. So in the cases that we're talking about, this is actually a torsades, because like the case that I put out, you know, the kid has a polymorphic VTAC, which, you know, we find out, I guess, by definition is torsades, because, you know, you take the ECG afterwards, and then he does have the QTC prolongation. And so now we officially call that torsades, right?
Yeah. Yes. I mean,
Gotcha.
Even if it was a young kid, you'd probably be like, I doubt this 5-year-old or 9-year-old kid is having a massive STEMI that's putting him into polymorphic VTAC. So odds are it's probably a genetic component, and long QT is a genetic component. So some clinical history can kind of help guide you, I guess, in that, so to speak.
Yeah. So I don't know when to get into the differentiation thing, because it's really difficult. So
it is so complicated.
It is super complicated. So anybody who's listening to this right now, like, hopefully you've looked at the blog first, because I'm going to be referencing a lot of that stuff, because I don't think this is the time to like try to talk about, oh, this wave looks like this and this wave looks like that. So go read the blog on it, and you can read about differentiation. But I want to talk about more like resuscitation here. I thought that we would start with this stuff that is similar, because when people look at the blog, they'll see that there's acquired, as in like they got it from you know, a medication, a toxidrome, an electrolyte abnormality or something like that. Like they acquired it somewhere due to some outside condition. But if it's congenital, and you'll see that in the literature, you'll see it as like C-LQTS, like congenital long QT syndrome is how they usually differentiate that. And like that, obviously they're born with it. And so there's a few different types that I differentiate in the blog, so you can kind of tell the difference between them. They have like different morphologies on their T waves. I've got pictures of all that stuff in the blog. So I thought before we go into like differentiating them, I thought it would be useful to talk about the stuff that's the same. So you have this patient, they have torsades. I have to stop calling it polymorphic VTAC. They have torsades for sure. It looks like torsades. I'm
sorry, I did that to you, didn't I?
Yeah. So we have this patient in torsades. How does that change our resuscitation? So let's go from like the pulseless patient, and we come upon this patient and they're pulseless. They have this on their ECG. Are there certain things, like obviously we know like chest compression fraction is super important. Like all the BLS stuff stays the same, but then are we still giving amiodarone? Do we only do the magnesium?
Yeah. So what's really hard is like, that's why I said, like, when you get there initially, I just don't, unless it's like overtly obvious and you're running like a PEDS code, then you can kind of be like, oh, I'm going to err on the side of a congenital issue. But, you know, most of the time when you show up on a code, you're just not going to know. And I think it's totally valid. Like obviously if the patient is in a run of torsades, they should be defibrillated, you know, some electrical therapy in there. And I think you're fine to try mag. Like, I think that that's just part of the normal H's and T's. If you know, the H's and T's algorithm for reversible causes and just approach it that way. And I mean, even if it was a generic form of polymorphic VTAC, I think the only thing that would really change is just run your code as it were, treat it for torsades, and maybe consider going to a cath lab facility, because that generic polymorphic VTAC is most often caused by cardiac ischemia.
Yeah, I think that's
the initial management.
Yeah, I think that's the big takeaway from me looking into the literature and stuff, is it's just magnesium. Like it's mag, whether it's congenital or if it's acquired, they're like really pushing the mag. And I was looking into, because I know that there was some of the literature that talked about, should you give lidocaine and stuff like that, and it really nothing was indicated besides the magnesium and defibrillation. So it made it actually like really simple. The other things that I know that you've talked about before is like considering, you made that infographic for the blog, was like, do they have an electrolyte abnormality? And so I was thinking about that a little bit, and I was like, you could probably throw like calcium in there, and then you've already given the magnesium. So it's like, if the calcium is low, if the magnesium is low, you kind of have those two taken care of. And so you can give those, obviously, to just carry them, But then the other thing I was thinking of, they always talk about giving potassium. And I'm like, unless you have LR, this might be an instance where you would give some LR, because it can normalize the potassium a little bit, but you're kind of out of luck if you think it's like an acquired case and like the potassium is low or something.
Yeah, I've found that like in most of the literature that I've read, or people who talk about these cases, it's like if you have one low electrolyte, there's usually others that are probably concurrently low with it. I think the three that I commonly see together is like hypocalcemia, hypomagnesium. Well, that's a mouthful. Low magnesium and low calcium, hypocalcemia. And it's usually those three that tend to be in conjunction and can kind of like, you can like, I know we didn't say we were going to talk about waves, but that's like one of the nerdy things about the 12 lead is you could literally look at the 12 lead and like and I don't know if this isn't right, I would have to look it up, but it's like if the QT segment is long, that's like specific for one electrolyte. If the T wave itself is like stretched out, that's making the long QT, like that's specific for another electrolyte. Like you could really get in the weeds of like running or trying to, like, I guess, diagnostically figure out which electrolyte is low just based on the morphology of what is actually spreading that QT interval out. So you can do that. I mean, I would imagine it'd be profoundly low for it to be causing those changes, but there is a way. Yeah, you could do it. That might be a next ECG blog.
I don't know about that. I'll let you take care of that one. But it's like the good news about the medications to fix it is like they're super benign. Like you're not going to hurt anybody with magnesium.
It's true.
You're not going to hurt anybody with calcium. And
so like here's a question for you. I got a question for you though. So you get on scene of this patient, and I don't know why this gets brought up, like with the medic program that I teach, is inevitably I'll get this question all the time. When you show up and the patient looks like they're in torsades, do you do the mag first? Are you shocking them first? Like given, in our system where we work, typically there's like an ALS fire engine that showed up. They don't have like all the goodies that the ambulance carries, but typically like, they've shocked or whatever, or they have IV access for you. Is there like a certain order of operations that you are doing? Like, is there one priority over the other, or is it like, are you delegating just out of curiosity?
I think the defibrillation always becomes the priority to me, like, and then the magnesium is to follow. I think it's just the order that you can accomplish the things. So like if you can, obviously the easiest thing to do, I think you start with the easiest thing first. And so immediate defibrillation as fast as you can, keep the chest compression fraction going up, good BLS care, and then magnesium afterwards is what I would say.
Where does epi fall into this for you?
So this is tricky because
this is where I was getting at right here.
Yeah. So, and this is going to be up to each provider. I'm not trying to talk anybody into being like, oh, this is when I'm not trying to tell anybody like, don't give, epi to these patients, do give epi to these patients. Actually, but in actuality, there is a correct patient to give epi to and probably an incorrect patient to give epi to. But people are probably going to follow standard protocols. But the crappy part is if the patient ends up being a congenital case, epi would have been the wrong move. And two, like, and this is just me just completely spitballing my own feelings, and nobody has to listen to it. But to me, any kind of VTAC or VFib to give them epinephrine doesn't make any sense. because of all that beta stimulation, but that's just neither here nor there. But yeah, you guys will see in the blog, everybody's listening to this, like you'll see in the blog that in the congenital cases, you want to avoid any sympathetic tone, but then in the cases of acquired, you want to give them sympathetic tone that doesn't hurt them. And so that's what makes them so sticky. So that is kind of like the crappy code situation, is during that initial resuscitation. And just me personally, I don't think that there's that much utility in the epinephrine to begin with. And especially if they have like unreal beta stimulation, like it doesn't make a lot of sense to me to begin with. But if I had a case of what I thought was torsades, I don't know. I don't want to go there, but I don't think it's useful. And I think that the magnesium, the defibrillation, the BLS would be the way to go.
You just toss that out there and you're like, oh, fingers crossed. We don't have to cross that bridge. But I mean,
I don't know.
And that
I don't know about that epinephrine, but because it would be useful if it was an acquired case and you thought that it was like,
yes.
Yeah, a toxidrome. And you were like, or if you got the story and like the kid had been having diarrhea, or it's a slightly older person, they take some weird medication, or they got into a medication or something like that. You might think like this could be acquired and that would be fine. But that really gets into the weeds if you can differentiate,
I think, in the moment, we can talk about, and I found that to be true for a lot of things, is we can sit here and we can talk about things or write blogs on this, and then you get stuck in the moment where there's so many other human factor elements to consider that your cognitive bandwidth just isn't able to dig that deep, sometimes. Yeah. So I think it can be tough. And then the other question that got sparked for me is like, if you're running these VTAC, VFib, where you're alternating the epi, amiodarone, like if amiodarone, is amiodarone the right antiarrhythmic in this patient?
Negative. Then it's not.
Yeah. See, so I've always, and I have no shame in admitting this, I like amiodarone because it's just easier to use. I feel like it's less, I've never given lidocaine on a code, and I'll be completely honest, the dosing scares me. I feel like it's going to exhaust that bandwidth that I have. A lot of times, in our system, occasionally when we would run in the county, like I'll be solo medic, and that's a lot to like, there's a lot of things that I have to consider. So I try to keep it super simple, for those parts. But yeah, like this would be a situation where, you will have to get familiar with lidocaine and its dosing.
Yeah.
For those that are not familiar with it, like me, a new medic, like, newer-ish, we were raised on amiodarone, 300, 150. If they got a pulse, 150 over 10.
Yeah. And these patients, like if you do have a presenting rhythm of torsades or polymorphic, because it would be really for either one. Like I think if I had either one of those rhythms, I probably wouldn't give the amiodarone. I would go with the lidocaine because that's a sodium channel blocker as opposed to the ami that's like blocking everything. The lidocaine doesn't prolong QTC. The amiodarone does. And so that's like some of the medications that you have to avoid in it, is that, you'd have to be familiar with like the lidocaine and stuff, or if they had like PVC. So maybe this is the point where we transition to like out of the code. So let's say we defibrillated this person, we had good BLS care. Maybe you gave epi, maybe you didn't, maybe you went with the lidocaine and magnesium, whatever. And now this patient has a pulse back, and now you notice that, whoa, this patient has a really long QTC. Now I know that's torsades. Now I know why they likely coded. And you can go into like the differentiation on like, if it's congenital, like I have a chart in the blog that goes through like, well, these congenital cases are more likely to be like exercise. These people may be emotional stress. These people maybe like sleep, like unaroused state and stuff like that. Maybe you get a story with that and maybe you don't. But there are like, so let's say you ended up intubating this person or putting in a supraglottic airway. I found some anesthesia literature that actually goes into like has pretty good case reports on like what's good to use and what wasn't. And what I found was like, it just was super old school. Like it was like fentanyl and Versed were safe. And what was it? Oh, and if you use a paralytic, like I don't know, you wouldn't, in a postcode, you wouldn't be using succinylcholine anyway, but succinylcholine wasn't really recommended because of the risk of it being congenital. But with the exception of one, all the non-depolarizing agents were fine except for pancuronium. So and nobody has maybe somebody has pancuronium, I don't know. But
It was like 2 months ago. I
Rocuronium,
found out. Yeah.
what's that?
Yeah. No, it was like 2 months ago that I found out that cisatracurium was like another. They use that in the ICU. I was like, what is
That I
this?
think I'm like going based off of memory right now, which is dangerous. But I feel like that was also, I think the only non-depolarizing one that was bad was pancuronium. So I think you can use anything else.
Definitely don't carry that.
Yeah. So, and most people get, you need to have rock, or they're going to use VAC. And so either one of those were fine, which is good, because if you were going to keep them down, like that would be the ones, but they mostly, and propofol was fine as well, if like you were in a hospital or something like that. So it was like really simple. It was like, the Versed, the fentanyl, propofol was fine, like really like the most common ones. But they did say, like, because of the risk that it might be congenital, they recommended going away from droperidol and ketamine, which would be super common in a kid, to just like give them ketamine, and and a lot of ERs and stuff.
Yeah.
Well, I know there's like a shortage of droperidol and stuff like that. I saw Jeff Jarvis post that up the other day or something, but that he finally got some. But that would also not be indicated, I think, because there's like some sympathetic tone to it. And so we're trying to, like, if it is those patients that are congenital, you try to withdraw that sympathetic tone. And so you kind of keep it safe by like limiting sympathetic tone with like analgesics and like just traditional sedatives. So that was kind of like, like my mental model I went through when I looked at this. I was like, okay, so just keep it old school. One thing they mentioned, but I don't think anybody would do, and I don't see like a reason anybody would do this, but it was mentioned in the anesthesia literature, was like they actually kind of go back old school, and they do recommend in these kids, like let's say it's a congenital case somehow, they actually do talk about giving lidocaine as a pre-medication to intubation, which is like, I remember when I was like, we were talking about this before the podcast, and you're like, that was being phased out. But like, I remember thinking that RSI was this like, and it is complicated, but I remember like learning it for the first time, and it was like, well, get your lidocaine out, and then get your atropine, and then get your fentanyl, and then get your Versed, and then give your defasciculating dose of Sox, and then this, and then, the regular dose, and then the continued sedation. I was thinking like, I'll never get any of this. This is so much at one time. But this actually does go into a little bit of that old school stuff with like the lidocaine pre-medication. Not something I think that we do in EMS and be up on that, but something that kind of drives home the point that like you really try to block that sympathetic tone and stop them from having like an issue with that.
This is why I say this was so much more like, we agreed to do this podcast, and I was like, yeah, for sure. And then I started doing the research on it, and I was like, oh my gosh, what did I get myself into? It's so complicated.
I did post a link to that anesthesia article. It's hyperlinked in the blog itself, where it says like, it's talking about acquired cases, and I have it says like medication, and then I have it hyperlinked. So if anybody wants to look at that anesthesia article, it goes through like, there's a huge list of stuff that can prolong a QT. The only stuff that I saw in there that we really carry that we'd want to avoid was like, some people carry phosphonatoin, but like, it's just the normal stuff you think of, like diphenhydramine, ondansetron, I don't know why you'd give them Haldol, but like all that stuff is like contraindicated in like the prolonged QT. You always see like that stuff on the box. It's like, may prolong QT, and you're like, I'll never run into that. And then then all of a sudden you're like, crap, what medications can I give and which ones can't I?
So that's definitely the acquired, right? So what did we say? The acquired, you either have drug induced, a patient who's on QT prolonging medications, and then you could have a clinical situation like a patient who's extremely dehydrated, nausea, vomiting, diarrhea for an extended period of time. And then the other one, on the other hand, which I know you spent far more time than I did on, because it's way more complicated, would be the congenital. And so there's like 3? Is there 3 total, each stimulated by something else or perpetuated by something else?
Like there's probably more. They kind of like, they kind of divert them down into those 3, but there's like a bunch of different, it depends how deep you want to get into, because there's like a bunch of different mutations that cause those presentations. and it does get complicated. But yeah, there's long QT1, and it's like this huge monomorphic T wave. There's long QT2, which has, it's kind of convenient because it has like 2 humps on it. It's like a double hump like this. And then there's long QT3, which is like, you got a bunch of ST segment, and it's like isoelectric line. And then there's like this narrow T wave at the end of it, but they're all prolonged. And yeah, I got a graph in there that shows them like what typically gets them to act out, which typically will send each one of them into like a fatal arrhythmia and stuff. So everything is pretty similar up until this point. Like good BLS care, magnesium, chest compression fraction, maybe like calcium correction of electrolytes, stuff like that. Don't give them anything that prolongs it directly. And then the sedation, like just really keep it simple with Versed, fentanyl is fine, propofol is fine, etomidate is fine. But yeah, those ones that stimulate the sympathetic tone, probably avoid. Those ones like droperidol and ketamine, unfortunately, we'd have to avoid. And then probably rocuronium or VEC. So here's where this comes to now is you've got them back. So we work the code. We figured out what medications can't we give in the code. Let's say that we, had to intubate them, place some kind of advanced airway. And now there's a little, so everything is pretty similar up until this point. Like we've taken really good care of this patient. We've prevented harm. We're really trying to do our best here. And then we'll save the last part of this because this is the super crappy part that you'd have to be really good to figure out is those patients that are congenital in an ideal world. Like let's say you knew like 100%, like I paint a picture in the blog of like a patient who you can pretty clearly tell is going to be a patient that's congenital. That patient should receive beta blockers, even if they're not having like arrhythmias, even if they're not having PVCs, like stuff, they should always receive a beta blocker because the congenital cases are exacerbated by tachycardia and then sympathetic tone. But on the other hand, the acquired cases, their hearts get pissed off when they have bradycardias.
When it goes slower. Yeah.
When they go slow. And so it's like congenital, you're supposed to beta block, and then acquired, you're supposed to give them something like isoproterenol with a bunch of beta stimulation, but you'd probably end up with like epinephrine or atropine. Do you feel like you would get to a point of comfort with this where you would, and this is probably a point where somebody would call online medical direction if they had this case.
Oh yeah.
But
for sure.
What would have to sell you to where you're like, I'm going to beta block this patient? Let's go with congenital first. Like what would have to sell you on it where you're like, I'm going to give that patient, 5, or whatever, the pediatric dose would be of like metoprolol or labetalol is what people usually carry. Like what would have to sell you on that? You're like, I'm going to call online medical because nobody has a protocol for this. And so you're going to have to call. What is going to prompt you to be like, hey doc, I think that we should give this patient a beta blocker? Is there something that would tip you off where you're like, I'm going to try to sell this?
I would start to get really suspicious the younger the patient is. And I think even if the patient was in their 20s or something like that, I would still like, this was just missed. Like nobody saw it. Their high school sports physicals didn't catch it. And so it's hard to give an age threshold, for it. It really is. But I still kind of keep it on my radar, or any congenital issues if I'm going on like a 20 or sometimes even like an early 30-year-old with like a weird syncopal. Like my workup is a little bit different for that. But I think the younger they are, the more suspicious I am of it. And if there's if the clinical history, the events leading up to don't sound like that they could fit a clinical situation in which I think they would have a low electrolyte level for whatever reason, I think I would start to grow really suspicious that this may be a congenital related issue. But yeah, that conversation with the med control, that would be a nice, long, extensive conversation for, being like en route to the hospital as you're trying to have this conversation or something like that. But I will say, I did have one lady who I'm fairly certain had Brugada syndrome, and she was like 55 years old, and she just had a wrist like a wrist little medical alert tag, and it didn't even say like her diagnosis or anything. It just said heart condition on it. And I was like, oh, well, I guess
Man,
that's
who
helpful.
made that
But
tag?
not like, yeah.
Come
And she was
on.
coded. She had coded. She had crashed into a mailbox and like had her syncopal episode. And yeah, we got there, and I was like, what medical? And it was like there was no taking it off. Like it was one of those that's like on there. And it just said medical. It just said heart condition. I was like, well, this is useless. So, I mean, there you go. She was like 55 years old. She had Brugada syndrome, I guess, is what we found out later. And I was like, well, so it's so hard. But I think what would prompt me to have a conversation would be somebody whose age doesn't quite fit the category with no clinical history.
Yeah, I think I'm pretty much, after looking into this more, I think I'm in the same boat. Like if they seem unlikely to have like some high dose of a medication, if they haven't been crapping their brains out or exposed to a toxidrome or something like that, and they're young, and this is kind of unexplained, I'm probably leaning to like, I'm gonna probably call online medical control and talk to them about this, because I don't want this patient to rearrest. And I don't want this to seem like it's only like, I think we've been like very specific in talking about like this scenario where they coded, we got them back, we're pre-hospital and stuff like this. We might also take a transfer like this where maybe they were diagnosed by the sending facility, and maybe the sending facility, I mean, we run into this all the time. Like there's just different clinicians with different comfort levels, and that sending, it's a critical access hospital, and we're taking a transfer to a pediatric center now. Maybe they didn't get a good consult, or maybe they didn't get a consult at all. Maybe it just rolled in the door, and now you're transporting a ventilated ped, and this may be what's wrong with them. And you need to have a conversation about this. It's worth at least being familiar with, like, oh, if they're going down this congenital route, like, do we have to did anybody give beta blockers? Do we have to do that? Did we talk to somebody about that? Like, even just getting that conversation going, like one or the other. And then if this patient ends up being some kind of acquired case where they find out, oh, they had a toxidrome, or they've had the flu, the stomach flu for a week, and we drew their labs, and their calcium was in the toilet and the mag was low, so we gave blah blah blah. Like, we might ask, well, should we give something to speed this heart rate up? Have they been having ectopy? Like, should we give atropine or start a low dose epi infusion to keep the heart rate up, and stuff like that. Like, I think that's a worthwhile conversation to have, because I agree with you. It's going to be incredibly difficult. It's in the back of your head pre-hospital in the rare instance you run across this. But even on a transfer, you want to be aware of this stuff, because like I said, there's going to be differing comfort levels and knowledge levels for these, critical access hospitals that you go to and who they consulted with and stuff. It's worth to at least be aware of.
Yeah. For this, so going back to your example, like say you had a pediatric and you were assuming it was congenital, their post code. Yeah. I feel like more often than not, that first initial blood pressure you get back, depending on how much epi you gave, I guess, can be soft. Are you still pulling the trigger on the beta blocker, even if the blood pressure is something that you're like,
I don't think you can.
Like, I don't know.
Because you might, if the blood pressure is soft, like that would be a really good use case for maybe like something with less beta stimulation. I think you would
like a vasopressin.
What's that?
Like if you needed to use, because like if you get that patient back, and this is highly specific, right? We're talking pediatric, congenital, postcode. Now we're preventing the recurrence of torsades, and they need to be beta blocked, but they're like soft blood pressure. It's like, can you, what pressure are you going to use? Because technically that's all beta adrenergic stimulation, but you need to get this beta blocker on board because they're, throwing PVCs. I see that this is the weird rabbit hole that you can get yourself into. Yeah. But I don't know what your opinion is on it. Like if it's a soft blood pressure, you're like, here, just slam this metoprolol, guy.
The first thing I'm going to be thinking of is, can I give a little bit of LR? Would be my first thing. Like, because if it is, there's still the risk that maybe it's an electrolyte or something like that. But I would be thinking, could I give a little bit of fluids? Would they respond to the fluids? And then you would probably get stuck using norepinephrine, because it's got less beta stimulation than the epinephrine. And it's not going to jack the heart rate up as high. It might even lower a little bit, even though it does have like that inotropic squeeze. that would make me more comfortable, regardless of if it was acquired or congenital. But you're right, man. This is like it's a deep rabbit hole, but it's one of those things like, so is a lot of the other stuff that's included in ACLS that you don't really see that often, but we still prepare for it, And so it's like, as you become more familiar with cardiology, like you want to know about Brugada syndrome, you want to know about long QT, you want to know about De Winter's T waves, you want to know about all this stuff that how often are you going to see it? I don't know, but when you do see it, you're going to be wishing you knew a little bit of something about it,
That's literally the number one motivation. It's like, man, I just don't want to get a patient that I have absolutely no clue what this is. Nothing terrifies me more than that.
Yeah. And it's like, it's one of those things where there was a podcast floating around about it, and then you just didn't click on it that one day. And then like you had it a week later,
That's exactly what happened. Yeah. I mean, that's how it always works. I'm sorry for whoever gets this call, like within three to five, like within the next week. Let us know how it went.
I will be very interested if they comment though. There will be somebody, if this gets enough circulation, as the circulation goes up, the likelihood goes way up that somebody will see a call, something like this, and then they're going to comment on this later, like, oh my God. So, well, I think that was a good coverage. I mean, I go into the real specifics in the blog, and I got to thank you for putting together that infographic as well.
Yeah.
Anything you want to wrap up with before we get out of here?
In the infographic that I made, it's just 3 simple rules, right? We just defibrillate any unstable patient, give that mag bolus, and then where you like those are the initial parts of the resuscitation are the same, whether it's acquired, congenital. The only time that you split, like it says in the infographic, is rule number 3, where you're just preventing the recurrence of torsades. There's a difference, right? Congenital, beta blockade, acquired, whatever means to speed up the heart. So I don't think we discussed overdrive pacing, but I mean, you can give it a try. Just set that pacer at 100 to 120 or whatever. But no, otherwise this was a fun topic to tackle. And I learned a lot. You really dig deep into cardiology. Sometimes it's like, I can only do a paragraph at a time. And then
and it teaches you more about other stuff too. Like I learned a little bit more about like traditional polymorphic and like stuff that would cause acquired in digging into the congenital and stuff like that. So it's good to study this stuff, even though, the chances of seeing it are pretty low. It teaches you other stuff in there. And then also you may just have that patient where it's like, you're looking into this congenital stuff. And then you realize like, wow, there's all these medications that like, you can't give anybody with a long QT interval. Like you got to kind of keep it simple with like the sedation and analgesics. And who knew that like there's certain even paralytics that would cause an issue or certain like just run of the mill medications. So yeah, all that long QTC, QT prolongation warnings that you see on stuff. It's like, oh, that's on there for a reason. And I might want to know about it.
I had no idea.
Well, man, I'm looking forward to your next, what's going to be the next ECG quiz and mini video. Do you have a topic picked out yet?
I think we just released the axis deviation. Mm-hmm. Was that one? So it was the shading method. Some people use the thumb. I think that's roughly the same thing. And then there was going to be a mini part series on like the differential diagnoses of the different axis deviations. That one will be real quick. And then I have like a whole list. I literally just close my eyes and point, and I'm like, oh, I'm going to do it on that one. So
I've got a request.
Oh, okay.
I want to see one on De Winter's T waves.
Oh, okay. I like it. I think let me see. Is it on my list? Oh yeah, it's there. Second to last one down. Yeah, right underneath Brash syndrome. Okay. No, it's second to last. I had written Brash syndrome because I think, giving credit to Jace, I think he brought it up a couple weeks ago.
In the thread. Yeah.
In the thread. Yeah. And I was like, oh, that'd be a good one.
Yeah. All right, cool, man.
So, all right, De Winter's T waves. We'll
gotta bump it up the list a little bit, man. I'm anxious to see that. I want to share it with somebody. So, all right, dude. Well, thanks so much for hopping on. I really appreciate you diving into this topic with me, and we'll see you next time.
Yeah, man. Thanks for having me.